the Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Hello, everyone. Welcome to another episode of the Dentalpreneur Podcast. I'm your host, Dr. Mark Costas. What's up, my friends? I hope you're doing great out there today. Oh, it's a beautiful day here in Prescott, Arizona. Finally starting to feel like fall. And, when you're watching NFL Sunday Ticket and it's 90 degrees outside, it just does not feel like football season. So I'm really happy that this weekend started to cool off a little bit. I'm really excited today to be welcoming a friend of mine that I met recently at the Dykema conference, and her name is Brenda McNulty. She's the owner of DSO Facts, and she has over 30 years of experience in the dental industry, specializing in transforming practices through innovative training and accountability systems. Her expertise helps teams both in office and remote operate more efficiently, driving profitability and success. As a sought-after speaker, Brenda has empowered countless dental professionals to achieve their ideal practice vision through her tailored approach and leadership. Brenda, welcome to the podcast. How are you doing today?
I'm doing great. Thanks for having me. I'm super excited today.
Yes. You live in one of my favorite states. I was just recently in Colorado myself. How long have you been in that area?
Gosh, I on and off. I graduated high school here and then moved to California for a while, and I've been back here since 2006. Absolutely love it. I'm in Arizona next week for a conference, but I always love coming back to Colorado. It's gorgeous here.
Yeah. Okay. I would love to hear. Well, first of all, what part of California did you move to?
I was in Oceanside and Temecula. I was married to a Marine for many years, so we were stationed on Camp Pendleton.
No kidding. Okay, awesome. Yeah, I'm very familiar with that area. My son goes to San Diego State. I went to UCSD. My wife went to San Diego State. So we're San Diego people. So I know your neck of the woods or where you were for a period of time. Tell us, Brenda, about your history in dentistry. What got you into the field in the first place?
Actually, it was California. The military had deployed too many troops over to Iraqi freedom.
Oh.
And they needed some dental assistants. So they put an ad in the paper saying, "Wives, we need you. Would you like to go through the Naval Dental Training Program?"
Oh, that's so cool.
So I have sucker written on my forehead when it comes to volunteering. So I jumped in, got the free trainings, and started off working on base for many different specialties, and then went out into the real world in the civilian life and started as a dental assistant and worked in many different capacities. I realized I was not a very good dental assistant. When I was assisting for the military, that's really all I did was amalgam fillings all day long. They called them WFTs, the whole frickin' tooth amalgams. And so when I got in the real world, I couldn't make a temporary to save my life and didn't even know what acid etch was. So found my space on the business side and been doing that for over 30 years, over 15 years experience as a dental consultant.
Cool.
With small and large practices.
That's awesome.
I love it. Great career.
That is, people ask me all the time how I transitioned from the clinical world into the business side of things. How was that transition for you? What exactly did that look like?
Well, it was actually by mistake. My doctor was taking the business team on a retreat to learn more about the software. And he told me just to assist. And the first patient walked in and wanted to know how much money they owed. And so I had to call the insurance to find out. Next patient walked in the door. They needed to make a payment. I had no idea how to do that. I had to call the software to find out. And since I was learning directly from the horse's mouth, you might say, I learned how to do things correctly right from the start. It wasn't she said to do it this way and she said to do it that way. It was directly from either the software company or the insurance company. And ended up learning so much that it was very evident I was better on the business side than I was on the clinical side. In fact, I got fired as a dental assistant and then offered to come back and interview for a position on the business team in the same office.
That's awesome.
So I did that. And you know you're a bad dental assistant when you walk into the room going, "Hey, doc, you're all by yourself. Let me help." And he goes, "No, that's okay. I got it. I can do it by myself."
That's awesome. That's awesome. So what does your business look like? So are you kind of a one-on-one consultant? Do you work with small groups, regional groups? What do you kind of specialize in the consulting world?
Well, I love this question because I no longer consider myself a consultant. I was a consultant for many years and I absolutely love it. And it works wonderful for most offices where I can get up all day and I can train and everyone says, "Great, let's take this information and let's run with it." What I normally work with now are the offices that say, "We love this information, but we don't know how to implement." So I am a fractional training officer.
Okay.
So what I do is we train on material, or we take the material that you learn at Dykema or at another meeting, and I train that material to your teams. And then we create an implementation and an accountability plan. And each of my clients has me for a fraction of my time per week, per month, to make sure that the implementation and the accountability program is working really well. It all started, I was at a very large meeting and I was sitting down with 4 or 5 different dentists and they say, "You know, we love all this information, but there's just no way that we can implement it in our practice. We don't have anybody like that. We don't have anyone that can be somebody that's the head of this training program, and we can't afford to hire somebody full time." So they all looked at me and said, "Could you do it for a fraction of your time with us and with them and with them and with them?" And that's how the fractional training officer route got started. And I absolutely love it because I'm considered a part of their teams.
That's genius. I mean, I've hired fractional CFOs before for my companies, and for us, it was hit or miss, but the ones that did hit were extremely, extremely helpful. And you're right. I mean, sometimes, in a startup or a young company, you do have the necessity for somebody that has, the CFO skill set, but a lot of times you don't have the budget for it yet. And I can see where this might be helpful for people that don't have that implementation or, executive level budget for somebody with your level of expertise. So, tell me this, like if you are creating systems and helping to get them integrated into an office, how can you make sure that after you're gone or after your job is done, that the leadership within the practice is strong enough to continue to run those systems and hold people accountable?
So that's the beauty of the design of this role. Before I leave, we create a implementation plan. What does that look like? Who's doing what, when, and how? So once that's created, then we say, all right, now how do we hold each other accountable? What does that look like? So sometimes, let's say we're going to switch a verbal skill. We're no longer going to confirm appointments. We're going to call patients and ask what questions they have regarding the 1 hour that's reserved specifically for them. So we've changed up a verbal skill. So how do I hold you accountable? I ask the team member, this is now your job. How am I going to know if you're doing it correctly? And they design it and say, well, how about if you listen to 15 of my phone calls per week? And then we meet and we discuss those. Okay, that sounds great, but what happens if you're not doing it? Then what? And it's almost like you're talking to one of your children where you say, you haven't turned in your homework. What should the punishment be? They go, oh, I shouldn't be able to go outside for 3 weeks. Their punishment is always worse. So when I ask them, what happens if you're not doing it? They're like, I'm going to do it. So if I'm not, please write me up. Please do this. Please do that. I'm like, well, that's a little harsh. How about some coaching? How about we listen to these calls together to make sure that we can do it? Because sometimes the plan needs to be changed. So that is the number one reason why consulting and training fails, is because I may be doing it right, but Stacy over there, she's not going to do it that way. So when I see she's not doing it that way, why should I do it that way? So we all have our own accountability plans to make sure that we are implementing all of that training and we're implementing it correctly. We also look at the KPIs. Like, how does this training and what you just learned, how is that reflected in the KPIs? So maybe this one particular one, when we're talking about changing a verbal skill for confirming appointments, maybe our KPI is that we have less cancellations, reschedules, and no-shows. So we'll be able to track it by the numbers as well as by the recording. And each and everything that we teach has some way, shape, or form that we can hold people accountable to. And the implementation plan goes right along with it.
I love that. That's really cool. Customized accountability plans. Very forward thinking. Do you work with CEOs of the companies, so the practice owners themselves, as far as creating an accountability plan for them?
Absolutely. My sweet spot is, working with not only the CEOs, but the teams, because the teams will say, oh, doctor's never going to do that. And the doctor will say, oh, my team's never going to do that. So we actually create it all together. And we have to look at the doctor and say, are you willing to do this? Are you willing to walk in the room for a recare exam, for instance? And if those intraoral photos are not up, look at the hygienist and say, I'll come back when they are, and walk out of the room. It'll only take once or twice for them to do that before the hygienist is like, oh, crud, I better get these intraoral photos there. But it's not human nature for these doctors that are running behind to do that. They're just like, okay, next time. So we do hold them accountable to certain things as well. My sweet spot, the name of my company is DSO Facts, but my sweet spot isn't the 50 plus locations. My sweet spot is the owner that owns 5 or 6 locations, not necessarily private equity backed, but somebody who's growing and has associates that they're mentoring and team members who want to grow along with the company. I'm not looking to be a fractional training officer for a DSO that has 50 locations, because that would be all my time. I would not be a fractional training officer. I would be their training officer. So I really like that sweet spot of doctors who want to grow and team members who want to make this a career.
That's very cool. What are some of the common themes you're seeing as far as everyday challenges that are holding practices back from reaching that next level? In other words, what are some of the main things that people are hiring you to overcome?
The biggest right now is RCM management. The revenue cycle is struggling, and that could either be because they don't have the right treatment plans, they don't know how to utilize their software correctly, or they don't have the verbal skills to collect the money on the day of service. So revenue cycle management is huge, because obviously you can track that very quickly and see a big return on investment. The second is team buy-in. We have so many teams that are overstaffed because they know 2 or 3 people are going to call out every single day. They're just not vested in the success of the practice, or the morale is so low that the turnover is super high. So we have to create a culture where everyone feels as if their job is a career and not a job. I say every day I go to fun, I don't go to work. And when it starts to become work, I'm not going to do it anymore, because I spend too many hours in a work week doing this. So I like to bring that along with the team. And then the third biggest struggle is schedule management, either the no call, no shows, reschedules, or the fact that they don't know how to fill their schedule productively. They don't understand the difference between a private pay patient and maybe one that is with a very low reimbursement PPO. They might have a day full of PPO patients where they don't even break even for the day. So we look at how we balance the schedule so we can accommodate everything that needs to be done in that day and still see a profit each day.
That's great. So what are some of your favorite strategies for overcoming that no call, no show last minute reschedule scenario, which seems to be more and more prevalent these days?
The first thing I do is take away anything in the office that says reschedule or cancellation. I don't allow the teams to go, here's your appointment for in 6 months. Mm-hmm. And if it doesn't work, just go ahead and give us a call and we can reschedule that for you. Instead, we use powerful words. It's very important that we find a day and time that you know for sure that you can honor. Mm-hmm. Can you commit to Tuesday at 2 p.m. or Thursday at 1 p.m.? Which one of those two will you be able to commit to? So we're setting them up for success. We're doing repetitive learning. So we're saying it over and over again. And then we're not saying things like, we're just calling to confirm your appointment at 3. We're calling to see what questions they have regarding the 1 hour that is reserved specifically for them with Dr. Costas. Mm-hmm. Like, we are being very particular with the words that we use. And then, of course, we're not allowing patients to abuse us. We have to, know when to cut ties with the patient and release them to the wild if they're not going to honor their reserved scheduled times, because it just doesn't work that way in our books. We need to make sure that we have patients that love, honor, and respect their dental home.
Yeah, so important. So important. I'm going to give you just a little mini case study here, Brenda. Just let me know what you think about this particular scenario. Say, you're used to consulting with, coaching, working with a number of different practices. Let's just say one practice has no problem with new patients. They're getting 90 new patients per month for maybe 2 full-time doctors. And then another practice, potentially in a different market, but similar demographic, is getting, say, 26 new patients for 2 full-time doctors. And you're looking at these 2 practices side by side, but the 90 new patient practice is struggling to do $1 million per year. So they're doing like $75,000 to $80,000 per year. But this other practice in a similar demographic with 26 new patients versus 90 is working on a $2 million year, right? So what are your kind of differential analyses going to look at to see what is happening in the struggling practice versus the one that seems to be doing more with less?
First thing I would look at is payer mix. Okay. Because if you're in network with a very low paying PPO, you can drop half of those patients, become out of network, and produce the same amount as if you had all of those patients. Mm-hmm. So I would look first at the payer mix. Second, I would look at case acceptance. Yeah. What is a case acceptance like in that one that's having 90 new patients? It does you no good to have 90 new patients a month if they're coming in the front door, but your back door is wide open and they're just walking through. So mm-hmm. What's our retention look like and what's our case acceptance look like? Mm-hmm. And then I would go to the thriving practice and I would check their phones. How many phone calls are they missing? What does that quality of the phone call sound like? Because maybe they're getting the same amount of phone calls, but they're not getting those new patients scheduled. So there's concerns with both of the practices, because what I do find is when somebody has multiple locations, their marketing almost always is the same for both locations. Mm-hmm. So if they're getting 90, they're probably getting the same amount of phone calls in the other office. It's just either they're doing a very good job weeding out those that should not be patients, mm-hmm. or they're not answering their phone and getting them to schedule. So there's a wide variety of concerns to look at that. The one that's getting 90 new patients, that would really excite me if they had a wonderful new patient experience. They would be producing more. Mm. Are they taking intraoral photos? Are they doing iTero scans? Are they asking just the basic question? Hand the patient a mirror. What are the goals for your teeth, your mouth, and your smile? And then by when? By when do you want this dream smile? I find that a lot of doctors are afraid to diagnose the patient's wants as well as their needs, and they're only sticking with the needs. And that is detrimental to a patient. Ask them what they want and diagnose that as well. So lots of different factors there, lots of things to look at.
That is really, really awesome. That's a really cool way to put a process to something that's pretty subjective, like the feeling that somebody gets when they're in your practice for the very first time. So if there's process wrapped around that, it's much more predictable. I am going to go, since you talked about case acceptance, it varies so much from practice to practice. And those are the things that I feel are really dependent often upon the strength of the treatment coordinator, the person that's actually conveying what the doctor has discovered in a patient's mouth. So do you feel as though that all of those skills are trainable? So some people are just naturally more charismatic and more charming and just would naturally get more yeses. You know, you hear about these people that they're like, oh, this person is a winner. They can sell ice to an Eskimo, right? So you have those people, but then you have other people that may not equal that same energy or that same charisma that are in the same position. Do you think that those people can be equal and you can get equal results from them if you structure their presentation similarly?
I feel like the politically correct answer is to say yes, but that's not the case. You have different personality styles. There are people that are so good with numbers that I never want to answer the phone. They're just not meant to be that director of first impressions, to answer the phone and really portray the brand of the practice. I feel like case acceptance starts at that website, starts at the phone call, and the doctor has to get the patient to say yes to the treatment chair side. I can get them to say yes to the money, and I can teach people to get them to say yes to the money. But if they haven't said yes to the doctor on the actual treatment in the chair, my chances are slim to none to getting case acceptance on the money portion. So we teach the doctors to say, this is what you need. This is why you need it. This is what will happen if you don't do it. And if it is cosmetic, if they're trying to get the smile of their dreams, then we use an if and then sandwich. If you want your smile to look like Julia Roberts, then we are recommending 12 veneers. Is that what you'd like me to do for you? Yes. Okay, they said yes to you. Now let me show them what that money looks like. But if they are in the back going, well, I don't know, then the doctor should say, tell me more. Tell me what it is that you do want. How can I help you? And if they come back with something like, well, I don't know if I can afford it, all the doctor needs to say is, if we could make this financially affordable, is this the treatment that you would like me to provide for you? If they say yes to you, give them to me. If they say no, that objection is a gift to you. It's telling you what you have to speak to in order to get the yes. So what is it? Is it time? Is it money? Is it pain? Is it results? But chances are the doctor has the answers to those objections. So once they go over all of that, bring them to me. I can sell a $50,000 case and I can sell a $50 case if the patient said yes, chairside. Very cool.
That makes a lot of sense. I like that if then sandwich. That's cool. I like that vernacular. So I have had lots of dental practices in lots of different markets. I've had practices in very blue collar markets and in very high end markets. You're talking about, maybe the average household income is $45,000 versus $120,000, right? And I found, that it's not necessarily any easier to sell treatment in the high end market. Sometimes it's more difficult because there's a lot of competition in those markets, and those people are very, considerate when it comes to how they're spending their money. And sometimes in those higher end markets, but on the other side of the spectrum, you have these lower socioeconomic areas where people don't necessarily have the financial means to do a large, FMR case, et cetera. But sometimes there's a sleeper in there, right? I've had farmers come in overalls and dirty boots with a coffee can full of $100 bills. And they're like, make my smile better, or take them all out and put implants in. I've had all different types of that. And that comes down to sometimes preconceived notions or actually prejudging people based on their appearance or based on a demographic, et cetera. So when do you open up that conversation to, hey, we have flexible payment plans, or hey, we have some options for being able to help you to afford this treatment? Probably terrible verbiage right there. But when do you open up that conversation like, hey, there's a third party financer that you might want to consider? Do you wait until they say, I can't afford it? Or at what point in that conversation does it go that direction?
Well, I think step number one is making sure the doctors are diagnosing what's in the patient's best interest based on their goals and not diagnosing their pocketbook. So
Okay.
you diagnose their mouth. What would you do for your mother? And then when you're asking them if they want this treatment, they go, well, I don't know if I can afford it. That all the doctor has to say is, we have lots of different financing options. If we could make this financially affordable for you, would you like to move forward? Then when I have them in my room, I've had people that have said, I don't have this kind of money. That's crazy. And I say, okay, well, what can you afford? On a $9,000 treatment plan, they go, I only saved up $8,000. Like, that's wonderful. We can take the $8,000 right now and we can either finance the other $1,000, or by the time your treatment is done, then you can pay the remaining. And they're like, wow. So in that case, I may not bring up patient care financing. Doesn't sound like they need it.
Mm-hmm.
But if they come in my office and they say, I'm on a fixed income, I'm on Social Security, my husband's retired, there's a lot of patient care financing out there that has wonderful resources. One of my favorite things is something that Care Credit has, which is like a write-on wipe-off paper. And I say, how much can you afford per month? I could afford $125. So I go to that board and I say where $125 are and the total amount that they're doing, and say, yeah, absolutely. You could have an extended payment plan for $125 and you'd be paying on that for 36 months. Or we have an option for interest-free for 12 months, and this is what that payment would look like. And I'm always asking open-ended questions. How does that sound to you? What does financially affordable sound like to you? Because what I have known in all of these years that I've been in dentistry is nobody comes and says, yeah, I want a beautiful smile. I want to do veneers. I want to do crowns, and doesn't expect to pay for it. Mm-hmm. Mm-hmm. They obviously know that dentistry is not free. So what is it that I can do to help them reach their smile goals? And the biggest obstacle I have in that is when some doctors don't give them the big picture. They'll say, oh, well, they really only need this crown and this filling over there. And later on, phase 2 will do this. Phase 3 will do that. Phased dentistry is what many colleges are teaching these dentists to do. Mm-hmm. But from my perspective, if I'm a treatment plan coordinator and I'm trying to go over this with you, the person sitting in front of me might be getting a home equity line of credit to pay for their dentistry. Mm-hmm. Or they might be applying for Care Credit or one of the other patient care financing. I want them to be able to get it all done at once, get that one loan for their home equity line of credit or whatever they're doing, and be able to meet their smile goals sooner, if that's what they want. Mm-hmm. But I don't want to limit them and have them just do this much and they later on go, oh, I wish I would have known that. I would have taken out a larger loan. So let us help you as a treatment coordinator. Let us help you give that patient the smile that they've always wanted sooner than later.
Awesome. Okay. Going back to our really simple case study, you gave us some really good tips. PPO fee analysis is important. Making sure that you're kind of analyzing the case acceptance or case presentation rather, to make sure that the correct words are being used and you kind of tighten up or improve that new patient experience. These are great tips. And then you also mentioned retention. So I have found that many times people are tracking their new patients, the new patient flow, but most times aren't tracking their retention or the attrition rate, rather, the number of patients versus the number of patients that are attriting out of the practice versus new patients. And a lot of times, sometimes you have really vibrant new patient flow, and you also have a really, really high attrition rate. And sometimes the attrition rate is outpacing the new patient rate. So although they have this front end feeling as though the practice is growing, it's actually shrinking because they're treating more patients than they're getting as far as new patients. What are some things that we could do to increase the retention of our existing patient base?
Okay, so 3 big things come to mind. If you do not have a dashboard, you need one.
Mm-hmm.
And you need a good one. You need one that I can get any information that I want, even information that's not available in the software, I can pull from a dashboard.
Mm.
I'm a huge fan of those. Second is every day in your daily huddle, you should be talking about who came in yesterday. So yesterday we saw 48 patients. 46 are back on the schedule.
Mm-hmm.
The doctor would be saying, which 2 are not? Like who did not schedule, right? So we're all talking about that.
Mm-hmm.
We want to get 100%. We want to get them all back on the schedule. We also talk about how many new treatment plans were presented yesterday. We had 8 treatment plans, 6 scheduled. Well, who didn't? And what's the backup plan for those 2?
Mm-hmm.
But when it comes to retention, most offices are only sending out past due recare notices, or they're calling it recall. I call it either recare or preventative care. I don't say you're due for 6 months. I say you're going to be due in March so that they can remember those things.
Mm-hmm.
And we work 3 different avenues. Coming due without an appointment, due now without an appointment, and past due without an appointment. If I don't work all 3 of those avenues, by the time I call somebody, it isn't until they're past due.
Mm.
And let's say they're 1 or 2 months past due to come in for their cleaning. And now I have to tell them that we're booked 3 weeks out. That's just not fair.
Mm-hmm.
Not fair to us and the schedule and to the patients. So let's work all 3, each on a different day of the week. Maybe you have different people that are in charge of it. But if you keep them on the schedule to begin with and you tell them it's very important. Stacy, I know your smile better than anyone. I've been your hygienist for many years. As you know, my schedule is filling up fast. Let's go ahead and reserve time in March so that we can evaluate this, and this. We have to say the reason for return. I use my husband as an example. He hates it when I do this, but it had been many years since he went to the dentist. And I finally convinced him after 4 years, just go. We have dental insurance, just go. So he goes, has his teeth cleaned. He comes home and I say, how was your visit? He goes, everything was good. Yeah, everything was fine. No cavities or anything. And I said, okay, did you set up your next appointment? And he goes, no, why would I do that? I go, what do you mean? Why would you do that? He goes, it had been 4 years since I had my teeth cleaned. And the hygienist said, everything looks good. We just need to see you in 6 months. Well, if everything looks good and I hadn't been in 4 years, why do I need to go back in 6 months? Mm-hmm. There was absolutely no reason for return. Mm-hmm. So he honestly, the analyst part of his brain was like, I can wait another 4 years. I'll be perfectly fine. I didn't have any cavities or anything.
Yeah.
So they're devaluing themselves. They got to say why they need to come back, what it is that we're going to be evaluating, even if it's simply oral cancers on the rise and your medical doctor looks straight through your mouth down your throat. But we're going to be looking at all of your soft tissues and checking for lumps, bumps, bruises, and squishy spots, whatever you want to say. But they have to know why they need to come back for their next appointment.
Awesome. I really like that verbiage too. Since COVID, the pandemic really kind of exposed a lot of vulnerabilities that we had in the workforce. A lot of people after the pandemic never came back to healthcare in general. Dentistry was hit particularly hard. So we're finding ourselves as practice owners with a limited experienced pool of potential employees to choose from when we have a vacancy on our teams. So what is your view on holding out for that experienced person versus training up newbies? And when you're forced to train up a newbie, what do you lean on as far as a process for onboarding them and training them?
I am not opposed to hiring newbies. For a business team, I've hired some amazing people from Chick-fil-A, from Nordstrom's, from Maurice's clothing store. In Southern California, I got a lot from Coffee Bean and Tea Leaf, because those companies, they really educate on customer service. So they have that personality for customer service. I can teach them the dentistry part. So on the business side, never a worry. For dental assistants, I also don't mind fresh out of school, because each doctor does things completely different. They use different materials. And if a doctor is easygoing enough that they can train, by all means, hire somebody new. Now, the training method that I use is I get the team together and I say, let's make a list of everything a dental assistant may need to do in the course of a year. We make that list, and then we'd say, okay, what's really important for them to learn week 1, week 2, week 3, week 4. So we break it down into a training plan for this new patient. And then we break it down even further and say, who's the best person to train them on this? Who's the best person to train them how to break down a room? Who's the best person to train them how to set up for a crown prep that could possibly turn into a root canal? And so then we have that trainer person, it may not always be the same person, that is responsible for making sure that that new hire knows how to do it. The new hire, as well as the trainer, sign off after the tell, show, do approach has happened. So there can't be any time that a new hire goes, nobody told me that, because we would have proof that they were taught that particular task. What I find is if you don't have some sort of a training plan, things get missed. I was in an office just a couple weeks ago, and I went up to a dental assistant who'd been there close to 2 years and said, hey, where's your AED? She goes, oh gosh, I don't know. Let me find out. Hey, do you know where the AED is? Hey, do you know where the AED is? And when we finally found the AED, we found out that their pads had expired in 2019. Right? So that was missed on all of their training plans. So when we think about it, we create this one, we're like, yes, you know where the fire extinguishers are. You know where the AEDs are. You know what to do in case you get stuck by a needle. All of those basic principles are written out on the training plan, and everybody is trained the same exact way. So a newbie versus somebody who's been on the job for 20 years, sometimes those are worse. Because they're like, no, that's okay. We can reuse these. We can just put them in the cold sterile. We can reuse them because that's what they did in their other office. They might have some bad habits that they're bringing along with them. Yeah.
I found the same thing. Sometimes a clean slate is refreshing, and they don't have any baggage or bad habits, or my other doctor did it this way, or, some shortcuts that don't serve the practice well. I'm going to ask you this question based on your experience. I've been doing this for a long time. I graduated dental school in 2002. I was a clinical dentist for 21 years. Sold my last 4 practices just, a year and a half ago. So I have seen a lot as far as the consolidation world. I've seen many DSOs come and go. Some of the ones that are prominent right now are relatively new. Less than 10 years old. And some of the ones that kind of started off hot and heavy in the beginning kind of fizzled out and disbanded and were unable to get money for recaps and just kind of had to separate and sell off into parts. What, in your opinion, makes a successful DSO, one that can stand the test of time? And maybe even perhaps what are some of the personalities or traits of the DSOs that are successful now?
That is a very complex question. So when I see a DSO, sometimes you can tell right away that they're going to work, and sometimes you can tell right away that they're not going to work. Part of the process is due diligence. Do they even have any clue what it is that they just bought? So looking at the information that they got before they purchased the practice is key. Like, what are they doing? Or are they just gobbling up practices? Because as you know, practices are not all created equal. And oftentimes they don't even understand, like, do I purchase the AR? Do I not purchase the AR? Nobody's even looked at the credits. Nobody's even looked at the outstanding claims. They think this money is coming in, but yet it's not. So the practices that I've worked with the DSO that are highly successful, they have a regimented system. They have a great due diligence. They have, this is how we're going to handle RCM. This is the type of technology that we're going to be using. And they have more of a individual approach to some things, but systematic approach to others. Like, for instance, if I might have an exact way I want text to pay options going out to all of the patients, right? Text to pay is great. Let's use that. But maybe this particular provider is going to be doing these types of services and not these services, and that I'm okay with that as a DSO. I don't come in and go, guess what? You can only order your supplies from this company. You can't have those gloves that you've used for the last 15 years. You now have to use this, because that is where people get a very bad taste in their mouth about DSOs. On the positive side, DSOs can offer things to team members that private practices just can't. The benefit packages, like, you can't touch some of those with a 10-foot pole if you only had one practice. So if they have the right systems in place, the right benefits in place, and the right training systems in place, they're going to be successful. But if you don't, prepare for that crash and burn, because it's just going to be a free-for-all.
Yeah. Awesome. Okay, I'm gonna end with this question. I want to be respectful of your time. Thank you so much again, Brenda, for taking the time to speak with us today. If you could wave a magic wand and change across the board how dental students are educated across the board, what would be what would be 3 of the top things that you would change as far as dental education?
Quit diagnosing their pocketbook, start diagnosing towards their goals. What is it that they want for their teeth, their mouth, and their smile? And what is it that they need? Let's turn those needs into wants, because they're going to purchase what they want long before what they need.
Good one.
That would be number 1. Second is, this is going to sound harsh, and I can say I'm not a dentist, so you may hate exactly what I have to say right now, but quit offering multiple treatment plans.
Okay.
If you say, we could put a filling in this tooth, or it might need a crown, the patient hears filling. And if we give them a treatment plan for a filling and then it turns into a crown, they're mad at us. But if we say, you need a crown, but guess what? We took a conservative approach, we're going to be able to fill this, they're going to love you. But the other way around, they're not.
Got it.
And then third, do not devalue who you are, what you've done, or what your education is. So quit saying things like, Mrs. Jones, you have just a small little filling on the lower right, because they think that just that small little filling on the lower right is going to cost them about 10 or 15 bucks. But we all know if that small little filling is touching 3 surfaces, it doesn't matter if it's a huge 3-surface filling or a tiny 3-surface filling. The 3-surface filling is a 3-surface filling price. So do not devalue yourself by saying things like small, little, just. Say what it is. You have decay. You have bleeding. You have recession. The good news is you've come to the right place, and I can help you.
Yeah. Subtle verbal adjustments make a huge difference in people's minds. And I really, really like kind of the reminder of that. Thank you, Brenda. That was incredible. Where can people find you?
Well, you can find me all over social media, but I do have my website is DSO Facts, FACTS. We're not in the 90s where it's FAX. DSOFACTS.net. That is my website. I'm, like I said, on LinkedIn, on Facebook, Instagram, all those great places. And I also attend a lot of dental meetings. It's important to me that I stay educated as well as being able to educate my providers.
Awesome. Well, it was a lot of fun. It was enlightening. I learned a lot. I took a ton of notes. My whole page is full of notes here. Hopefully you and I will bump into each other again at a live event. And I really enjoyed our conversation today.
So did I. Thank you so much for having me on.
Awesome. Awesome stuff, Brenda. All right, ladies and gentlemen, the owner of DSO Facts, Brenda McNulty.